By June 4, 2026, the data from Central Africa was grim. Health authorities confirmed 363 cases and 62 deaths across 17 health zones in the DRC and Uganda. The pathogen responsible is a filovirus, an RNA virus that aggressively attacks human host cells, carrying a staggering case fatality rate of 70%. For this specific Bundibugyo strain, there is no curative treatment and no approved vaccine. Because Ebola requires direct physical contact with bodily fluids to move between hosts, the virus typically hits a biological dead end as soon as basic hygiene and isolation are applied. We are going to deconstruct this specific outbreak to see exactly how standard epidemiological protocols failed, resulting in a public health emergency of international concern. Understanding this failure mechanism is critical. In our highly connected system, a localized systemic breakdown instantly translates into an international health security threat. This map details the outbreak's origin in Ituri, DRC. Rapid spread across 17 health zones forced Uganda to close its border on May 27th. The agent is the Bundibugyo Ebola virus. Existing vaccines lack cross-protection for this specific strain. The natural reservoir is believed to be fruit bats. Zoonotic spillover occurs through direct contact with these animals or through handling infected bushmeat. Once it crosses into humans, specific demographics bear the highest risk. In this outbreak, the host data shows a heavy toll on healthcare workers and highly mobile artisanal miners. The biological triad of agent, host, and environment is standard for Ebola. However, the specific environmental variables of this region catalyzed an uncontrollable crisis. Once a person is exposed, the Ebola incubation period runs from 2 to 21 days, with a mean of 8 to 10 days. This timeline illustrates an absolute biological rule of Ebola. Pre-symptomatic transmission is entirely absent. A patient becomes contagious only when symptoms physically appear. Contrast this with COVID-19, which relies on a massive 40 to 50% pre-symptomatic transmission rate to achieve high spread. Ebola transmission requires direct physical contact. The virus must enter through broken skin or mucous membranes via high viral load bodily fluids or contaminated fomites. There is one notable long-term transmission exception. The virus can persist in the semen of recovered male patients for up to 9 months, making sexual transmission a documented risk long after the initial infection. The virus does not spread through the air, through water supplies, or via mosquito vectors. Because transmission demands direct fluid contact and relies purely on symptomatic patients, rigorous isolation should mathematically halt the spread. The fact that it didn't brings us to the first major systemic failure. In early May 2026, a cluster of severe illnesses and deaths was reported in the Bunia Health Zone. Investigators faced a critical diagnostic blind spot. The PCR testing kits deployed in the Democratic Republic of the Congo were calibrated exclusively for the Zaire Ebola virus strain. They completely missed the Bundibugyo virus. This mismatch carried a severe epidemiological consequence. While the diagnostic tools returned negative results, 246 suspected cases accumulated in the community before official confirmation could trigger international emergency protocols. The gold standard for detecting these pathogens is reverse transcriptase PCR, but to be effective, technicians processing these samples must use broad panel diagnostics capable of detecting multiple viral species. That specific delay in laboratory confirmation provided the virus an unmonitored window to spread outward, eventually crossing into 17 distinct health zones. Field epidemiology is entirely dependent on diagnostic precision. If the PCR specificity fails to match the regional threat, rapid response systems remain dormant while the virus multiplies. To successfully choke out an Ebola outbreak, the World Health Organization targets a contact tracing rate of greater than 90%. The reality on the ground in Ituri was disastrous. Contact tracing stalled at a critical 44%. An infected U.S. missionary required an intercontinental medical evacuation to Berlin, while suspected cases triggered rapid surveillance alerts in Milan and Brazil. This global map highlights the specific biological threat to aviation, the virus's 21-day incubation period. Infected individuals can easily board international flights symptom-free, crossing oceans before the first fever strikes. To counter this, non-endemic countries rely on layered defense architectures. India's immediate response serves as a textbook model. The administrative layer activated on May 22nd Aviation protocols mandated self-declaration forms for all inbound travelers arriving from high-risk African nations. The physical port of entry layer relies on continuous thermal screening and visual symptom checks, operating daily at major hubs like Ahmedabad's International Airport. The domestic clinical layer backs this up. The surveillance network activated immediately. Isolation beds were readied across multiple states, and the National Virology Lab was designated for rapid PCR turnaround. International defense is entirely reliant on exploiting Ebola's long incubation period through strict administrative and port of entry screening layers. Without an approved vaccine for the Bundibugyo strain, medical teams have no pharmaceutical shortcuts. Treatment is strictly symptomatic, relying on fluid maintenance and pressor agents to keep patients alive. Containment requires intense physical engineering. It demands dedicated isolation wards with attached bathrooms and stringent continuous environmental sterilization to destroy the virus on surfaces. The highest point of vulnerability for healthcare workers occurs during the doffing of contaminated gear. Removing these layers requires highly regimented protocols and constant supervision to avoid accidental exposure. On a community level, responders execute a ring isolation strategy. They systematically isolate confirmed patients and rigorously monitor concentric circles of their known contacts for 21 days. A vaccine simplifies the logistics, but absolute discipline in executing these physical, non-pharmaceutical interventions has successfully crushed every previous Ebola outbreak. This advisory outlines the ground-level directives required to break the transmission chain. Every action, from isolating the symptomatic to enforcing safe burials, denies the virus its physical path to a new host. The kinetic lesson of this disease is that because it lacks pre-symptomatic spread, it is beatable through basic surveillance and isolation. The diagnostic lesson of 2026 proves that PCR panel specificity must constantly adapt to the regional threat landscape, or cases will slip through the cracks. The global lesson is that port of entry screening is never an overreaction. It is the vital firewall against incubation period travel. Biomedical tools and aviation protocols only work if socio-political conditions allow them to be deployed. Ultimately, community trust remains the absolute gatekeeper of global health security.